Well, it's the chest discomfort that has an unusual, uncomfortable characteristic. It's generally fairly severe. It comes on in a crescendo manner. It may radiate to the jaw, to the teeth, to the shoulder, for instance. But in general, a person can't put their finger right on it. It's more of a widespread discomfort. And it's often accompanied by shortness of breath, sweating, and an overall feeling of doom on the part of the patient. The patient clearly does not feel good at all. They generally know that they're in trouble. If they already have nitroglycerin, we generally recommend they take the nitroglycerin. If they have a regular aspirin available, we ask them to go ahead and take it, chew it, in fact, if they can, and wash it down with a glass of water. And then if they really are very, very uncomfortable, they probably ought to have somebody drive them to the emergency room. Family history has a huge role, primarily in terms of how which risk factors the person has and how the person responds to those risk factors. Hypertension, for instance, tends to run in families. The severity of it, not necessarily, but there is a tendency. Second risk factor is high cholesterol, in which particular type of high cholesterol. There's an abnormal lipid profile that's characterized by a high LDL, or bad cholesterol, and there's a profile that's characteristic, marked really by a low good cholesterol. Both of those are risk factors for the occurrence of coronary artery disease, atherosclerosis, the development of vascular disease, and so forth, even stroke. The American Heart Association has been able to clearly document that there is an improvement in survival, there's an improvement in treatment. We have set goals in terms of the speed of treatment, and we've refined them to a shorter and shorter time period as time goes on. We have a program here that is actually directed by one of my partners in the catheterization laboratory in concert with the emergency department, and we have a specific series of steps that occur very promptly when somebody shows up with a clearly has a heart attack. And that ultimately culminates in the patient going to the catheterization laboratory, hopefully within an hour to 90 minutes, and having that artery opened. Somewhere around 30% of myocardial infarctions presenting as sudden death. In the presence or in the vicinity of a center, so say someone here in Omaha who has a heart attack, there's lots of places that have emergency care for that. So if they survive to the emergency facility, the mortality rate is actually quite small. It's that initial group that has the cardiac arrest where the numbers are not good at all. In people with any risk in their family, I think they probably ought to at least get a blood test, check their blood pressure, and perhaps do that on a yearly basis, or maybe every other year if it's a lower risk. Certainly diabetics and young people who have already been diagnosed as hypertension, they should definitely be under the care of a physician.